organ allocation at our public hospital, we have 1 liver available and 2 eligible candidates. Patient A, a 25 years old with no prior illness, and patient B, a 55 years old with history of alcohol-related liver disease who is currently stable. Our goal is to reach a reasoned decision that is legally defensible and ethically sound. Dr. Haris, please present the clinical findings.
Thank you, Miss. From a clinical perspective, patient A has an exceptional prognosis with an estimated 5-year survival rate of 80 to 85%. Because of their youth and lack of comorbidities, surgical risk is significantly lower. Meanwhile, patient B, while 55 years old, is medically stable. Her 5-year survival rate is slightly lower at 70 to 74%. I must emphasize that modern transplant ethics rejects automatic exclusion based on past alcohol use. Patient B has been compliant and stable. However, if we look at the graph utility, patient A is statistically likely to provide more years of life for this single organ.
To ground this in Malaysian law, we must first acknowledge a statutory lacuna in the Human Tissues Act 1974 regarding allocation. Therefore, we are bound by the National Organ Tissue and Cell Transplantation Policy. This policy requires us to balance equity, unbiased assessment with utility, maximizing life years. Legally, we cannot use patient's B history of alcohol use as a moral disqualifier if she has met clinical sobriety protocols. Our decision must be logically defensible to avoid negligence claims under the 4 Fiona cases standard and must not be arbitrary per Article 5, Clause 1 of the Federal Constitution.
Okay, here's the thing. We are facing a classic conflict between utilitarianism and with justice. So, for those of you who don't know, utilitarianism, in a simple sense, sounds like the word utilizing for the greater good of the public. In this case, following the utilitarianism perspective, we favor more towards the patient A, who has a higher survival rate with the single organ. However, if we are looking into the justice perspective, where everyone is treated fair and just, we should not discriminate patient B in this sense just because they have a history of alcohol liver disease before this. So in this sense, we must ask whether we are treating them according to the fair and relevant differences or if we are just being prejudiced.
I must advocate for inherent value of patient A's life. Choosing patient A is not making patient B any worthless. It is about distributive justice. Patient A is at the start of his adult life. Choosing patient A is depriving him of the potential decades of his life that patient B has already afforded. It is about fair innings argument that everyone deserves to reach a certain age of their life.
I strongly disagree. Using the fair innings argument, here is a form of ageism. Patient B is 55 years old, hardly the end of life, and has been a compliant and stable patient. Malaysian guidelines requires us to distribute organs without discrimination based on social status and also the cause of illness. If we penalize her for her past alcohol use, we are making a moral judgment, not a clinical one, which is a violation of the principle of justice.
But we must consider that patient's A graft survival is statistically higher. Is it not our duty to ensure the organ lasts as long as possible?
Only if the MELD scores the medical urgency are tight. If patient B is more urgent, the law of equity says she should come first, regardless of her past.
So now let's look at the decision pathway. Mr. Mio has mentioned that the MELD score. If the medical urgency is equal, can we use the utility as the tiebreaker?
Under the doctrine of legitimate expectation, if clinical urgency is tight, the committee can favour the patient with the higher long-term survival rate. In the specific case, patient A to ensure the decision is logically defensible.
However, the Malaysian Medical Council guidelines states that age alone should not be the determinant for the access of the organ, because in this sense, justice allows for material resources to discriminate when the resources itself is scarce. So if the clinical benefit for patient A is substantially greater than patient B, therefore it is not an act of prejudice. It is merely an act of resourceful resource management.
Okay. So it seems that we have reached consensus. We will use the MELD-based assessment first to satisfy the requirement for equity. However, given the significant difference in projected life years and long-term graft utility, patient A will be prioritized. This decision is not based on moral worth or blame for patient B's history, but on objective clinical criteria of long-term prognosis and utility. This ensures we comply with Malaysian Ministry of Health policy while minimizing the tragic loss of potential life years. We will document this reasoning meticulously to ensure it remains legally defensible.